also give a shout out to Ashley Gregory. She's from the Northern California Foundation. Hey, Ashley, thanks for joining. Anyway, Shelley and I have had some wonderful and amazing conversations about women and bleeding disorders. And so after hearing her story, it's very powerful. I asked her to come join us to share her story and talk about what are the tips that she did to advocate for herself. I think a lot of women feel it's hard. It's hard to get a diagnosis. There's a lot of obstacles. And I do want to say that we have a HIPAA compliant survey that a PhD student from USC has been in the process of creating for our community that we will be sending out soon so that we can identify exactly what the obstacles are for treatment and for diagnosis, so then we can then take action, whether it's with our local HTCs or to get funding and grants to be able to get the treatment that the women deserve and the women need. So we welcome Shelley, who is from Trinidad, California, and she has over 25 years of experience in the field of education. She has very strong ties to the bleeding disorders community with an amazing and shocking 6 generations of hemophilia A in her family. And fun fact is her sister Shauna has joined us here, and Shauna lives right here in Santa Clarita. So thanks, Shauna, for joining. She also writes for a column in Hemophilia News Today. So if you're not a subscriber, you can join that group and you get an email with kind of updates on what's happening in the bleeding disorders community. So thank you, Shelley. Sorry, that was kind of a long intro tonight. Take it away.
Thank you, and I just unmuted myself. I am going to share my screen and bring up my presentation for you. And I have to get into my presentation view. I'm sorry, this is my first time doing this on Zoom, so thank you. And I think there we are good to go. We're going to start with a couple of poll questions that we're then going to loop around to at the end of the evening, just to get a sense of where everyone's at. And before we get started, I just want to give a shout out. There are a lot of awesome women on this call who I adore, and a lot of awesome women who I look forward to getting to know. So I'm really excited that you're here and that we're spending some time talking about how to empower women. And then also, if you're a parent of someone with mild or moderate bleeding disorder, a lot of this information is really relevant for not just women, but for men with mild bleeding disorders as well. So let's start. Casey has the polls for us. We have 3 poll questions. So how do you identify? I have a bleeding disorder. I'm a symptomatic carrier. I'm a carrier. I do not have a bleeding disorder, but am a caretaker. I don't know, or other, and tell us in the chat. And I'm going to let Casey knows when to turn it off and share. So looking at the sharing, looks like a majority of us are either have a bleeding disorder or other, and I am not going to head into the chat right now because I'm afraid I'm going to lose my presentation if I do so. And then we have some who are carriers and symptomatic carriers, and some who are caretakers, which is great. And I see the chat room flashing, so I'm hoping that there's some good identification in there as well. So let's move to the next poll question, which is your treatment plan and what you think of it. I have a solid treatment plan. I need or want to fine tune my plan. My treatment plan needs a lot of help. Treatment plan, what is that? Or other, and you can tell us in the chat. And hopefully we'll get that in. I see my chat lighting up a little bit again. Okay, so only about 1/3 of you feel that you have a solid treatment plan. quite a few of you need some help. You either don't have one, you need some help, you want to fine tune it, and some of you may be fine tuning a plan for someone else. I don't know if that's come up in the chat. And let's go to the final one, and we're going to compare answers at the end and see if hopefully you gain some valuable information. Your knowledge base. So I understand and can advocate for the treatment I need. I need more support and knowledge to advocate for my treatment. Help, I don't know where to begin. Or you might have something else that you'd like to tell us in the chat. All right, so let's see if those results are in. I love that over 50% of you say that you understand and can advocate for the treatment you need. That's super important, particularly as women with bleeding disorders, because sadly, we often have to do a lot of advocacy to get the treatment we need. And then about 40% of you, which is still a very high number, say that you really need more support and knowledge. So I hope that I can give you, over the course of my talk this evening, some tidbits and some knowledge that will help you advocate for your care. And this is very strange doing it on Zoom because I can't answer questions in real time, but we are going to answer questions at the end. So as they come up, feel free to put them in chat. Casey's going to be watching them for us, and we will definitely get to them at the end. And it's super important to me that we answer your questions. So I am going to start with tonight's learning objectives. I would like you to hopefully gain some knowledge to be able to approach your provider, to gather information to share with your provider. That's something that's important. And understand documentation strategies. That to me is probably the most important piece of information you can get tonight, because understanding how to document and share your issues is a critical component to fine-tuning care, and certainly was for myself. Okay, you are not a waste of expensive medication. And I put that as my starting slide because I can't tell you how many women have heard that they're wasting expensive medication. And that's not just Factor, Stymate, other medications, anything used for bleeding disorders. I have personally heard it 3 times myself from doctors or medical professionals in my care or providing me with care. About 5 years ago when I moved to this area, I went and saw a local hematologist, and it was a woman, and she was in her 60s and had, I think, a day or two of bleeding disorders awareness and treatment back in medical school. And she said to me, "What a shame that we would waste good Factor on someone with 20% of their own Factor." And because I had been at least a little educated at that point, I immediately responded back, well, if a man with 0% Factor goes in for surgery, you bring them up to 100%, but you would leave me at 20? And she looked at me and kind of paused and said, well, I hadn't thought of it that way. And I have more stories I can tell, and I'm sure that many of you could be sharing your own stories right in the chat right now of times when you've heard that as well. You are not a waste of expensive medication, and we deserve treatment. When we approach our providers, we come with our own perceptions. So you see the perception pyramid that I put here. What we think and impacts what we say and what we do and how we're perceived. So if I believe I am a waste of expensive medication, that impacts the way I approach my provider. Or if I believe, well, you know, I might be bleeding, but it's not nearly as bad as when my dad used to bleed. He was a severe. It might minimize the treatment that I'm attempting to obtain. We really need to think about where we are at, because our personal beliefs will dictate how we reach out. And it will also set the tone with our providers. And our beliefs really are as critical as the provider's belief in order to get care. And I'm not saying that we go in and demand care and are combative. In fact, I don't tend to agree with that. I think that we end up doing far better when we approach our providers in gentle ways, yet we have to know that we're deserving of treatment. There is so much that is still unknown about women and bleeding disorders, and there are so many misconceptions out there. These are a few that have been shared with me by the many women I've had an opportunity to speak with over the years. So you will only need factor for surgery or an accident. Many women and men with mild hemophilia have heard this. Girls do not need to be tested until they are ready to have children. We don't need to know your factor levels or if you're a carrier. And I'm just going to quickly say that girls need to be tested early on and quickly, just like the boys, because if a girl has low factor levels, we need to know that before they're in a car accident or before something happens. We want to make sure they're safe. If you took factor and it worked, it was a placebo effect. Mild women rarely bleed. And I know of at least 3 women in my close circles who have been told this. And my personal response is, you know, while that may be true, it may also not be true. It's likely to not be true. And we still need research on women with bleeding disorders. So I have a problem with a medical professional saying something is a placebo effect unless there's been a double-blind research study proving that it's a placebo effect. So as much as one doctor may think it's a placebo effect, and they have the right to believe that, my belief that the factor worked is just as valid of a perception, particularly in the absence of research. And we know that there's a huge research void for women with hemophilia or any bleeding disorder. We can't get stuck on the numbers, which we often do. There are many different labels that women have been labeled: carrier, symptomatic carrier, mild hemophilia, factor VIII deficient. All 4 of those have been labels that I've personally had in my lifetime. Moderate, severe, von Willebrand's, platelet disorders, all the more rare factor deficiencies, factor V, factor II, I'm not going to name them all, but we've all been labeled. The problem with labels is sometimes we look at numbers and labels and they impede our ability to access treatment. And that's when a label becomes a problem. So we have to make sure that we're looking at bleeds and bleeding issues and not just numbers and labels. And a lot of different factors, pun intended, can go into the realities of why we bleed. And often there are compound issues for many people in our community. I wanted to go ahead and give you the labels as they are now because they are changing all the time. When I first looked at the CDC's definition of mild hemophilia, I believe the number went up to about 35%. Here are the current ones specifically for hemophilia A and B. Under 1% is still severe and 1 to 5% is still moderate. But as we learn more, that mild category keeps expanding. So the CDC has mild as 5 to 50%, and over 50% factor levels with bleeding issues are now being labeled as symptomatic carrier. Now, the World Federation of Hemophilia is a little different. They have 5 to 40% as mild and 40 to 60% with bleeding issues as a symptomatic carrier. And I do think that things continue to evolve and change all the time. And I imagine that we're still going to see some evolution. I imagine that the World Federation will probably continue to evolve as well as we learn more about the fact that milds really do bleed and have issues. And individuals who carry the genetic mutations for hemophilia have issues, even sometimes when they're at significantly higher factor levels. I also just want to put a plug in here for chromogenic testing for hemophilia A and B. Chromogenic testing is one of the tests that you can do to test factor levels. The most common test is in the United States is a one-step factor assay. In Europe, they use the chromogenic regularly as the main tester. In about 30% of the individuals with hemophilia, that chromogenic test is going to show as lower than the one step. And in many cases, that's more accurate. And in some cases, particularly for milds, can make the difference of them being in or out of range to get a diagnosis. So I like to let individuals know that that test exists, so that that is something that you could discuss with your provider as a possible test in your lab work if you're looking at trying to figure out why you may be bleeding. But I don't bleed like my severe son, father, or nephew. These bleeds are easy to spot. When my dad bled when I was growing up, we knew he had a bleed. When some of you who have severe sons, or you have severe fathers or brothers, you knew when they were bleeding. It often blew up. They were screaming bleeds, and we knew to treat immediately. Now, I'm not saying that severes don't sometimes have questionable bleeds. Sometimes they have more mild bleeds that we don't know how to detect, but often they're big bleeds. So they stand out, and our medical community has been used to treating these types of bleeds for a really, really long time. And sometimes you'll see a mild get a severe bleed. I had one after a hysterectomy, the screaming bleeds that no one could ignore. Some of you have had them after giving childbirth. I bleed like a mild, slowly dripping. I believe that you deserve a faucet that does not leak. And it is so, so important that we remember that as milds and as women, we're more likely to drip like a slow faucet than have that big, large bleed. And that's important in our perceptions as we think about how we might approach our medical providers. Do you ever ask yourself the question, am I bleeding? I know that I have asked it many, many times in my lifetime, many, many times. Women in hindsight report tons of suspected untreated bleeds over their lifetime. And the more I learn about me and my hemophilia, the more I look back and say, oh yeah, when I was in 5th grade and cut myself and it didn't heal for a month and a half, that was most likely a bleed. When I had stitches 5 times before the age of 5, every time I cut myself, my parents had to have me sewn up to stop the bleeding, probably connected to hemophilia. When I tripped up the stairs in college and had my knee swell so I looked like I had 2 knees, probably a bleed. So I think that we can look back and over time see that we were bleeding. And sometimes we just had pains that lingered for months and months, and they weren't big swollen things. My ankles always hurt when I ran growing up. And I was told I was crazy and lazy, and I wasn't either. They were microbleeds. I know that now, but I didn't at the time. So dripping faucets can cause more damage sometimes. And why is that? And I guess it's rhetorical because I'm not in the chat at the moment and you're all muted. So I'll just answer it. But dripping faucets can cause more damage because we miss it and it takes longer to get to it. When I slam a finger in the door and it turns purple, I've got a raging bleed. I infuse immediately and it's done. But when I have a hurt knee and I limp on it day after day after day, it takes a lot longer for me to figure it out. And by the time I do figure it out and treat, I may be treating for a week or 2 instead of days. And we find that particularly as women diagnosed later in life, we've learned how to ignore a lot of pain. And it takes a while to re-key into it and understand that there are things going on that might need treatment. So what do we tell parents of severe boys? We tell them, when in doubt, treat. And treating doesn't just mean factor. It can mean rice or stymate or other options that your treatment center might have, but it means acknowledging it when you're in doubt and really working to make sure that you're taking care of yourself. And this message isn't yet always transferring to girls and women. Research shows that higher trough levels can be needed for protection. A trough level is the lowest point, the lowest level your factor gets before the next infusion. So years ago with severe boys, they would try to get them to 1%, and they thought that would be protective. Now, some of the studies coming out of Europe, now that we've rendered a lot of severe boys more mild with Hemlibra and other treatments and Prophy, now they're saying that we might actually need a trough level of closer to 20 or 30%. And if at any point any of you want links to those studies, let me know, and I'm happy to give them to you, because it's nice to have the research sometimes to back us, especially if we need to share that with a medical professional. This is the part where I really start sharing tips, because I think it is so important that we know how to advocate for ourselves. And the other thing, I just realized that I missed something going back. If you're in doubt of a bleed, you can always ask for imaging. Ask for ultrasounds, MRIs. They can show both long-term joint damage, but they can also show an active bleed in the moment. That is something you can ask for if your healthcare provider isn't sure you're bleeding. Trust yourself to know if a provider is a match for your care needs. That's something that is really important. I switched providers a little over a year ago. My provider was okay for my needs. I think I definitely needed fine tuning, but my daughter's provider was a problem. So I had the opportunity at the National Conference for Women with Hemophilia a couple years ago to meet with a doctor there who said, your daughter's care is wrong, get her to this clinic. So when I moved her to a new HTC, I followed with my care because they had a female sensitive clinic. There are 45 HTCs in the United States, including Children's Hospital of Los Angeles has a teen clinic, that have specialized clinics where an OBGYN and a hematologist come together under the auspices of an HTC in a joint appointment to problem solve. It's amazing. As someone who's experienced it at an HTC, it really, really helps with understanding women and their care. I'm going to link, you see the CDC screening tool. I'm just going to bring it up for a quick second. Hopefully it will launch like it is supposed to. I see a lot of things launching on like my Gmail from my work, but I'm not actually seeing the screening tool. There it is. So this screening tool is something that I want you to be aware of. It's on the CDC website. And when I spoke with Michelle the other day, she said that this will actually be distributed to you SoCal women. And it is a great way to, again, start to collect data that you can share with your healthcare professional. I'm going to go ahead and close that and get back to the presentation. The other thing that I found helpful for me was when I moved to a center with a pediatric unit, they were great. I had asked my prior HTC to teach me how to self-infuse because I was really bad at it. And severe boys learn often in camp when they're young. So adult clinics sometimes have not had to teach people how to self-infuse. And I found that when I was lucky enough to be at a pediatric clinic, they really, or an all-age clinic with peds included, they really took the time. They spent about 4 hours teaching me how to be self-sufficient and self-infuse. And it was so empowering to be able to feel like I could manage that part of my healthcare in an emergency. And I really encourage all individuals connected with hemophilia, even if you're a caretaker, to learn how to self-infuse for that empowerment. When approaching your provider, you need to have an attitude of openness. That can be really hard when you've been turned away and pushed away for a long time. And I try to tell women to not bring the garbage from your last HTC or your last hematologist with you to the new one. I think if we come in with a chip on our shoulder making demands, we can really quickly alienate our providers. It's totally understandable why we would. I just don't think we can necessarily get as far as quickly as we want when we have that reality. So I ask that you be patient if you can and give your MD time to get to know you and your bleeding patterns and work with you to tweak your plan. I know I wrote on here, expect it to take 6 months or more. I felt like I had that time. Sometimes you don't have that time and you have to push for more just a faster timeline. And I'm glad that I haven't had to do that. And my personal feelings about myself were, I haven't died yet. And I've been through some major car accidents and surgery, and some of them without factor, and I managed. And I was going to give my new treatment center the time. Another thing that I encourage you to do is ask them what they think signs and symptoms of bleeds are. And I found that in switching my care, I've gotten very different answers. So with one of my treatment centers, I would call and say, my knee's bubbling and it hurts a little bit. And they would say, well, do you have a bruise? And did it stop hurting within an hour of factor? Because if not, that doesn't sound like a bleed. And then I moved to a different treatment center that said, oh, your joints aren't going to bruise. And chances are it's not going to swell. You need to look for very slight swelling and small places where your skin is displaced, and check your range of motion. And there's a bubbling, tingling feeling, the same one that I had been told didn't signify a bleed. So I would just encourage you to talk to your treatment center about what you believe you're feeling when you're bleeding and what they want you to look for in terms of bleeding. I would encourage you right away to ask for help in creating a treatment plan, even if your own care hasn't been fine-tuned yet, because we need to know that when we walk into an ER, we're going to be safe. It's so important that we protect each other. Remember to say thank you a lot. I think that that's really, really important. My first treatment center denied me a PK study. That was something that I wanted done, and I'll talk a little more about that with the next slide. But I made sure to really thank my second treatment center when I had the opportunity to get it. So I would say ask for tests you believe you need and explain why you believe you need them. I need a PK test, which a PK test looks at half-life of factor. So I want that because I don't believe the factor is working. So this is where I say, if there's one thing I want you to get out of tonight, it is document everything with logs and photos and share them often with your HTC. And anything you can possibly photograph. I'm going to share some examples in a couple slides from now of things that can be photographed and just how, so that you can get some ideas of what you can be looking for to start photographing your own bleeds to document them for a treatment center. And when you're documenting, document your pain. And with pain, like if you're using a pain scale 1 to 10, pain scales worry me because we all have different ratings for pain. My 5 might be my doctor's 2. I might say to, so I like to use a shared experience. Hey, Mr. Doctor or Miss Doctor, did you ever have a wisdom tooth removed? When I had that removed, that was like a 5 for me. So right now my knee is a 7. It feels worse than having my wisdom tooth removed. And that, by creating that shared pain experience, it allows you to give them a better sense of your rating of pain and how it lines up with something that they understand. And then definitely document what is and isn't working. ICE works, ICE doesn't work. Factor did or didn't work, DDAVP or whatever you might use. What I did is, as I documented this, I would just send it to them and say, this is information for my file. I wasn't yet making demands, just here's information, will you please file it? And I'll tell you a little bit more about that process when I show you the photos in a few minutes. Request imaging, like I said before, if you really think you're bleeding and perhaps they're not sure. That one of the things research has shown is that both with patients and with our providers and treaters, we get the bleeds wrong. We think we're bleeding and we're not, and we think we're not bleeding and we are. So imaging really helps us fine tune that. Request testing, different labs to make sure there aren't other compound issues going on. A pharmacogenic study, a PK study, which looks at your half-life. When I was denied the half-life, I was actually told that it would be a waste of expensive factor if I wasn't on prophy. And then I ended up, needless to say, at another treatment center who tested my half-life, and the half-life should be 12 hours, roughly, give or take. Sometimes they'll say 8 to 12. And we recently found out in the last couple months that mine is 4. So I really wish I had actually pushed harder before when I sensed there was a problem, because I found out indeed that deep inner sense was right and I should have gone with it. Research your mutation. I can't say that enough. I was lucky. I was able to participate in My Life, Our Future before it closed, and that was really valuable for me. And I got the report back, and honestly, my HTC mailed it to me and I stuck it in a file, and I think they stuck it in their file. And then I had the opportunity to hear someone from My Life, Our Future, one of the researchers, speak. And they said at the conference, when I heard them speak, that they put a lot of information in that report for patients and for doctors so that we can use it to guide our care. And I went, well, I'm bleeding more than I should be bleeding with my factor percentage. What's going on? So I got home from this conference and I pulled it and I took it to my new HTC and I said, I think we need to look at this. And I found a sentence in that report that said in vitro expression of this variant demonstrated reduced binding to von Willebrand factor. And I brought it to my new hematologist and said, is this why I'm bleeding more? And she looked at it and she looked at me and she said words that were music to my ears. She said, I don't know, but I'm willing to look into it. Let's see if we can figure this out. And I think that when we have providers who are willing to say they don't know, they make the best partners in care because they research with us, and it's a real gift. So they researched and they called Milwaukee and didn't really get very far, but they were trying to research for me. And I researched and I went, there are quite a few articles on my variant, so I got lucky. And I found the principal researcher who had done the most research on my particular variant. And my research took me to Belgium. I wish literally, but just by email. And I got in touch with the professor who headed the study in Belgium. And what he told me is that my particular mutation causes a reduced binding to von Willebrand factor. That's what stabilizes factor VIII in the bloodstream, and actually they travel together. And I learned that only a third of my factor binds to von Willebrand. And because of that, only a third of my factor is really functional factor. So even though I have a number at 20, my half-life on my own factor is very short because the part that doesn't bind ends up clearing my system faster. So I learned a lot of really critical information by researching. And what is great is that if I go to another HTC, I come now loaded with research articles. This is part of what's going on with me. And I really need you to understand that I have crazy bleeding tendencies, and my variant helps explain it a bit. So that's genotype, which is the variant, versus phenotype, which is the actual bleeding patterns or bleeding tendencies that your doctor sees. And I would also say, don't give up. If you know something's wrong, don't give up. I knew that the factor wasn't working right, and I was glad that I revisited it with my new HTC and asked them to do that PK study. It's so important that we fine tune our care that way. I want to give you a quick lionization lesson, all of about 3 minutes, because part of what happens, particularly those who may live in rural areas, is that we go to a hematologist, or even if you're not in a rural area, you show up at the ER and they say, you're a woman, you can't have a bleeding disorder or hemophilia. And that's when it's important that you understand lionization, also known as X inactivation. That way you can explain to them, well, no, actually, this is how women get it. My good X chromosome doesn't necessarily compensate for the X chromosome with the hemophilia mutation. So early on in embryonic development is when X inactivation happens. Men have 1 copy of the X chromosome, and we as women, females, have 2 copies, but we only need 1 copy. It becomes redundant to have 2. 1 copy then of each of our X chromosomes is in each cell is randomly inactivated during this embryonic development. And in a truly ideal statistical situation, when I interviewed Carol Casper, she said, you know, half are above 50 and half are below. And ideally we'd all be at 50 because we'd get half from each parent. But it doesn't always work out that way. And my sister and I are great examples because my lionization didn't work out so well. And I am at 20%, and we believe she's up more in her 80s. So that's a huge discrepancy. Being able to explain how that process works can sometimes help access treatment with some medical professionals who aren't necessarily experts in bleeding disorders. This is where I tell you about documentation. All but one of these actually occurred in a 6-week period at the beginning of last summer. The picture in the top right is actually one that happened more recently. I think my arrow can go there. So you see, I just hit my knuckle and it blew up purple. And I did my little markings to see if it would spread. And I just sent that to my HTC to show them. But the rest all happened before I had any major treatment plan in place, and we were trying to figure it out. So I'll start with the top left-hand corner. I show that is an injury. I grated my thumb in the cheese grater. I took a picture of it. 24 hours later, you see that it's trying to scab, but still a little moist. Took another picture. 27 hours later, whole thing opened up. By 48 hours, it had totally stopped bleeding, but with no scab and a hole in my skin. And that is what was happening regularly. You see in the next picture, my HTC started to talk to me about looking for very slight swelling and displacement. So I learned how to do that. So my left thumb had gone out, and you see the reduced range of motion on the bottom and the slight swelling on the top. I took those photos for them, and then 1 hour after factor, the swelling was reduced a bit, and then you'll also see my range of motion returned. Going to the next one, again, looking for just slight displacement, I had a lump behind my ankle after 3 days of 5+ miles walking that was about the size of my ankle. And you see 12 hours post factor where the ankle is more defined. So the bleed went down and you could see my ankle. Going into the bottom left-hand corner, another ankle photo, less defined and more defined. And moving over, you'll see my knee, and you see where it's a bit swollen, and then 4 hours after factor, the swelling went down. Next to that, we've got some bruising. I stubbed my toe, and it just kept getting darker and darker. So at 36 hours, it was dark, and at 48 hours, it was spreading and still going darker. I finally realized that maybe I needed to take factor, and then 12 hours after infusion, you see it's gone, completely gone. And then the very last photo was what I call my gift bleeds. They're so easy because you know you're bleeding right away. I had bumped the back of my arm on a chair, a wooden chair handle at work, and I didn't even think it was that bad. And I couldn't see it because it was at the back of my elbow, and I went through work, and by the end of my workday, I could not bend my elbow. And I finally went to the restroom and looked up, and I had this big bubble of a hematoma there with a bleed, and got factor pretty quickly. Another thing that I did with my HTC is I noticed things. I used to ride my bike. I ride my bike 5 days a week. It's my stress release. I would ride my bike and I would injure myself, and my knee kept hurting over and over again. And I reported to my HTC, you know, it's kind of interesting. When I hurt my elbow and I was on factor for the elbow so I could still ride because my knees were fine, I found that my knees hurt less. So I explained that my knees were hurting less as I was taking factor for another injury. And I just kept sending it in. And my goal was to send these over a time period of 6 months, and then go in and sit down with them and say, hey, let's look at everything. And can we figure out what's going on? And I have to tell you, they actually beat me to the punchline. These were the 6 weeks worth of photos I sent in, and 6 weeks into it, I got an email from my HTC saying, you know, Shelley, we agree with you. Thank you for sending the photos. You're great at documenting things. We do think that you're bleeding more than you should. Would you be willing to consider a 1-month prophy trial? And it was so amazing that as I shared without demand and just started letting my Hemophilia Treatment Center know my bleeding tendencies, they were able to put it together, and the whole team talked, my physical therapist, the nurse, and my hematologist, and they came up with a plan. And I'd like to think that, to be honest, I probably could have gotten there. I hope I could have gotten there with my old HTC. I never shared information like this because I figured out how to do that after I had already left. I really like to believe that it's possible that they may have come along with me. And I'm not there yet with my short half-life. We're doing a bunch more genetic testing, and I hope to learn more in the coming months. And I'm thrilled that I have an HTC and a hematologist willing to keep researching and try to figure out what's going on and to not minimize. and not say, well, you just can't be bleeding, to look at the photos and look at the evidence and see that there are things going on. And I hope that for all of you, that you can get to that point. I believe strongly in community involvement, and I just want to say that, first of all, we help ourselves and we get our plans, but then it's important to reach out to the community. I spoke at a family camp for Oregon last summer, and there was a woman limping around, and I asked her what was going on, and she said she had surgery 6 weeks earlier. And I said, well, is it possible you're bleeding? Oh no, the surgery was 6 weeks ago, I'm not bleeding. And I said, okay. And that was kind of the end of the conversation. And 2 weeks after family camp, I get an email from her saying, thank you for telling me I might be bleeding. After family camp, I went to my HTC, and it turns out I did have a bleed, and I took Factor, and I feel so much better. And I think that we need to remind each other as women, because people told us growing up, many of us, that it was in our head. And we now have to get it out of our head and realize we have issues. And I like that we can hold each other accountable to getting that treatment. I went on Reddit maybe 6 months ago, and I posted an article about women with bleeding disorders. And a man got on and said, women are just carriers. They can't bleed, can they? And then I sent an article on lionization right after that. And he said, thanks, that's good information. And I pretty much thought that was the end. And 10 days later, he got back on Reddit and he said, thank you so much. I had my daughter tested. Her factor level is in the 30s. She now has a mild hemophilia diagnosis. It took me all of 5 minutes to post those articles. And now a young girl is on the radar for getting treatment. So I never underestimate the power of even a very small comment that you can make. I also want you to be aware, of course, we can participate in local groups, national groups, international groups. With social media, know your source. Make sure that your source is a good one, because sometimes not so great information is shared on social media. And I want you to know that there are other excellent carrier groups in the same boat we are. And a young woman in her 20s by the name of Taylor started an organization called Remember the Girls to highlight all X-linked carrier groups and the issues they are struggling with. Fragile X, Hunter syndrome, Alport syndrome, there are many. You can Google her and find the website. But know that there are many other communities with X-linked carriers who are also now finding out that indeed they too have symptoms and they need treatment themselves. Oh, sorry, I was going to move on to another slide. I got ahead of myself. And then, of course, you can be on advisory boards, you can speak, you can write, you can find your voice. And it's important that we all find our voice and feel that we have the right to share our stories, or our daughter's stories, or our mild and moderate son's stories to get the care we need. HFA Blood Sisterhood is a great place to share stories, and NHF has Victory for Women, and also through your local chapters. And I really encourage you to embrace your truth, and your truth knowing when you need help and when there are issues, and to advocate first for yourself and then for your sisters in our community. We know this is what hemophilia looks like. This is that stereotype, and we kind of assume that dominant male norm. And yes, that gorgeous boy in the middle is my nephew. Many of you in SoCal may recognize him because he's been to your events. And in the top right-hand corner is my dad. And then I had some friends who were willing to let me share their pictures. So we know this is what hemophilia looks like and what bleeding disorders look like. Now we need to get to a point as a community that we can move past this in the general medical community, and also just in the general community, biology textbooks that still say this is hemophilia. And we need to move and shift so that people understand that this is also what hemophilia and what bleeding disorders look like. And these women sent in these photographs for me. Yes, they're all connected, and they sent them in for a video I made. And when they signed the release, they said that I was welcome to use their photograph for educational purposes. So I thank them for being willing to share part of their story and being willing to be that female face of of hemophilia and bleeding disorders in women, because we know that it's a real thing. So with that, before we open it up to questions, I want to bring that poll back. So Casey, if you can bring the poll back, let's see. And she was going to take a screenshot and show us if anything changed. So how I identify, let's get that back up. And let's see if we all still feel, because we read those CDC definitions. So it might be that you've been told you were one thing and you read that CDC definition and realized you might actually fall in a different category according to our nation's CDC. And we will wait for Casey to flip up those results and see if it changed at all.
So I am going to end it right now. So
Okay.
we have 73% with I have a bleeding disorder, compared to before we started, we were at 42%.
Wow, that is an incredible difference in understanding. That is huge. So let's bring up the next question and see if there are any differences. So this is in treatment plan. I have a solid treatment plan. I need or want to fine tune my plan. My treatment plan needs a lot of help. Treatment plan, what is that? Or other? Let's see where we're at now. It's really fascinating to see how, when we educate ourselves, how it shifts. All right, Casey, where are we at?
So we are at, let's see. So actually, results for this one, I need or want to fine tune my plan, is at 36%. Before we started, it was 14. And I have a solid treatment plan is actually the same, 32%.
Great. Well, I'm excited to hear that 32 still feel that they have a strong plan, because I think that's important. And I think it's great that others are looking to fine tune their plan. I think that that is very helpful. And then the last one was knowledge base. I understand and can advocate for the treatment I need. I need more support or knowledge to advocate. Help, I don't know where to begin, or other. And let's see if there are any changes there.
Okay. I'll let it go just a couple more seconds. It's very active at the moment.
And then from there, Casey has been monitoring our chat room. So from there, we'll go to questions.
Okay, so we have 61% at I understand and can advocate, compared to 52% before we started.
That's cool.
So that's a big change. And actually, before we started, 39% said they needed more knowledge, and now we're down to 26%.
Nice. So I hope that that's valuable. And what I really hope is, beyond the knowledge being valuable, I hope that those of you who need this knowledge to take it and apply it to fine tune your plans, I hope that you're able to apply some of it and really see some differences for yourself. And at this point, we're going to open it up to questions. And I think with the questions, I'm going to go ahead and stop sharing my screen, because I want to see all of you as we ask questions. That's better. I love seeing your faces and not just my screen.
Great. So our first question for you, Shelley, is, sorry, I'm just getting in front of me. What is the best time to get factor levels tested? I know stress and hormone levels make a little bit of a difference.
You know, this is where I have to say, I need to give the disclaimer, I'm not the medical professional. So I really, really would encourage you. I'm an advocate. So I teach you how to advocate for yourself, and I give you all the skills to advocate, like gathering photos. But when it comes to an actual time, I would really encourage you to discuss that with your healthcare provider. You might be able to find some research on it that you can bring with you. There is information out there and research out there that definitely says hormones affect your factor levels. So you're going to want to work with your provider to time that in a way that makes sure they're getting the most accurate read. It is my understanding that sometimes a chromogenic factor assay can help with that. So I would actually have a joint conversation about the chromogenic factor assay and whether that is something that you would need, and also looking at the timing of when to take that test. It's a great question and a really, really important one.
Great, thank you. Our next question is, are mild, moderate, or severe women dosed the same as mild, moderate, or severe men, or is the recommendation different?
And that's a great question. And again, I would say that you need to talk to your provider about your dose. Usually doses are done based on height or based on weight and where you need to get for treatment. So for example, when I'm dosed, they need to get me up to 100%, particularly with my short half-life. And every treatment center deals with this a little differently. Some will dose up to 100% or higher, some dose to 60%. And there's actually some conflicting information. There's some, women and men saying, hey, what's up? Is this a standard of care or not? Should there be a standardized care? And I think that that's something that people are working on, and it's good that it's being questioned and they're looking at that. So it's really up to your treatment center. And I think it also depends on the type of bleed and what's going on. And I really encourage you to talk to your provider and again, ask. And I know many women who have had to ask, if I was a man with the same factor levels, would I be getting the same treatment? And I think that that's a fair question to ask as well.
Thank you. And we're just going to move on to our final question of the night before I hand it back over to Michelle. We're going to do something a little fun before we sign off. So our last question for you, Shelley, is about anemia. How do you treat anemia?
And I am not going to answer that question because I really feel it's more of a medical provider question. So what I would say is we definitely know anemia and bleeding disorders go hand in hand. And it's something that is really important to talk with your provider about. But because I don't have a medical background, I would encourage you to talk to your provider about what is causing your anemia. It can be caused by many different things, not just bleeding. Bleeding can certainly be a part of it. And I think it's important to talk to them. And that's why I also like to advocate that I don't believe in any one treatment plan for anyone. I do not believe every individual with hemophilia needs to be on prophy. My nephew's factor levels are half mine and he's not, and I am, because we have different bleeding tendencies. I think every person with a bleeding disorder has to be looked at individually by their healthcare provider. So for some, that may mean prophy, some that may mean DDAVP, some may get really, really lucky and only have to do something in an emergency like they claim all milds. So I think that with anything, whether it's with your treatment plan and looking at bleeds or anemia, any of those critical care pieces, you need to discuss your own personal situation and all the factors that influence your situation with your care provider, and hopefully have a care provider that you can have those conversations with. The ones like mine who say, I don't know, but I'll research with you. You want to make sure that you can partner in care and get that fine-tuned.
Thank you so much. And thank you for taking the time to present tonight. That was wonderful.
You're welcome. And I'm happy to hang around in chat like after we're done for a few minutes if anyone would like to chat or has a few questions.
Thank you. I'm going to pass it back over to Michelle.
Wow, thank you so much, Shelley. That was a very impactful, and getting all these private messages from women just thanking you for your information. And I know we've just really skimmed the surface. Everyone is different, but I 100% agree with you that women need to advocate for themselves and get the access they need. And I just want to reiterate that if you can take that survey that we send out, that will be very helpful. A lot of people are motivated by data. And so if I can come out with some data like 60% of all the women in Southern California are having these obstacles, then we can actually take action. So this is our last English-speaking virtual women's gathering. And I wanted to do a little graffiti art so that you could take home a little, I know this is a little corny, but I wanted you to be able to take home a little souvenir. So, and this is also another Zoom lesson for you. If you can see can you raise your hand if you can see my whiteboard? Can you guys see my whiteboard? Okay. Okay, so Casey is going to give you the instruction, but I think if you can leave an encouraging note or picture for your blood sisters To remember this time, this will be your COVID-19 souvenir. So 40 years from now, you can tell your grandchildren, this is what was happening to all of us during this crazy time. Leave an encouraging note. You can print this out. I'll email it to all you guys. Post it on your refrigerator and remind yourself that you have support. You have support with all of us and all your blood sisters. Casey's going to explain to you how you can actually draw on our graffiti board.
Super easy. If you guys look to the top of your screen, you should see a little green bar that says you are viewing Michelle's screen. Right next to that, it'll say view options with a little drop down bar. If you look towards the bottom, there's something that says annotate. Just click on that and a little toolbar is going to pop up for you to draw, to type, to stamp, whatever kind of picture you want to do.
Love it. A lot of hearts. There's an eraser too if you want to remove anything. All right, I'm gonna just give it 10 more seconds because we are at 8:22. I love the house. You can stamp your name if you want with the little arrow button. Very cool. See, we're so artistic. I don't know why those arrows are not staying. Okay, I'm gonna save this and send it to all of you. Our graffiti wall. Save. Let's see, I gotta save it somewhere. Let's see. Let's save it here. Save. Okay, you can see all my crazy Dropbox. I hope I saved that, Casey. I don't know. Whiteboard saved. Okay, great. Do you want to unmute everybody so we can say, whoa. Oh, the sun is really noisy.
Sorry, I
We just
couldn't do
want to
nothing.
thank you all for joining us, especially some of you who've been on for 8 weeks straight. And one last thing, I just want to see, I know it'd be super noisy, but we have 2 birthdays coming up. I know someone has shared their birthdays for us. And so where's Edith and Vicky? I think Vicky was on when I saw you, right? Where are you, Edith and Vicky? There
I'm
you
right
are,
here.
Vicky.
I'm in my house.
All right, we are going to sing you happy birthday. I don't know what it's going to sound like. I'm going to try to get my phone and record it. And whoever has a good voice, it's not me, maybe lead us in starting. Okay, ready? 1, 2, 3. Happy birthday to you.
Happy birthday to you.
Happy
Happy
birthday,
birthday to you,
dear
Edith. Birthday to
Edith.
you. Happy birthday to you.
Well, that sounded awful, but woohoo! There. There's a 1-second lapse in sound.